Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone. Thank you for joining us for today.
Good evening, everyone. I am Dr. Mahmoud Fauzi, radiology consultant at SGH Riyadh. It gives me pleasure to introduce our head of department and chairman of interventional radiology, Prof. Sultan Al-Qahtani, who will talk to us about the recent advances in management of acute ischemic stroke. So our dear Prof can start.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Mahmoud, for the introduction, and I thank the Saudi German Hospital and their groups for the invitation and for giving me this opportunity to enlighten and give shedding thoughts and enlightening the people about the recent advances in acute ischemic stroke. I know there are a lot of people with attendees who have the significant experience and awareness about the recent advances about this very, very interesting and very common disease. And for the recent year, we are really lucky about what have been done regarding the publication and research and development in the advancement in the field with respect to the management of acute ischemic stroke, which create a huge burden on the healthcare system and the families taking care of these patients. Start with my home institution, which is the King Fahd Medical City, which I started the Neuro Interventional Center and the Stroke Center 12 years ago. And my initial experience with stroke is almost 20 years now. And I did the first stroke on a young patient, which we will see it during the presentation. This is the Stroke Center in Riyadh that we have in installment now and should be ready soon. And start with a stroke about the stroke code. Stroke code is a huge concept, and it carries a very moral concept and a huge ethical impact on the patient and the healthcare providers with respect to providing the appropriate management for such patients, whether you are in the governmental hospitals or in the private sector hospitals. I think the government hospitals has to provide the maximum healthcare services that in their hands can be performed. However, with recent changes in the global economy and the healthcare transformation, there is a huge impact on the private sector to take the maximum share of providing such services to such patients. So all acute ischemic stroke, which is I will speak particularly in this presentation about acute ischemic rather than hemorrhagic. We will have talk after 2 days about the both ischemic strokes, whether hemorrhagic or strokes. So all acute ischemic strokes are accepted unconditionally and managed accordingly without discrimination, without seeing there's nationality, whether insured or non-insured, whether whatever condition of the patient, this patient has to be managed. And there is no excuse that I could wait for approval for such cases to be managed. That's totally non-ethical and has to be solved if this case still exists. All acute ischemic stroke will go through a stroke screening process from the ER and the stroke code activated immediately. Actually, the management of acute stroke in the relatively mature system start prior to hospital arrivals. This is a screenshot from our practice. This is the center, and this is me and Dr. Sinani, who's stroke neurologist, and we are being close partner for the last 20 years. And the aim of this picture is not the time to talk. So I am accusing myself and Dr. Fahmy being in the corridor and talking and while the stroke code is activated. So this talk can be done after we do the case. And this is the Angio suite, and we are happy after doing a case successfully. So thank you, Dr. Fahmy, for sharing the discussion. However, it's not the time rather than helping patients. So this is usually the Angio suite that we are performing our cases on. We have biplane FD20 Philips machine, which for me it's the appropriate tool to have this procedure done, and other accessories is just a complementary. So there are fundamentals of a neurovascular practice, and the fundamentals of which everybody should keep in mind in such providing such services is the expectation that specialties are growing too fast. So, and still the growth doesn't meet the demand. So there are huge needs to have these people who are in training to fulfill the requirements. And globally, even in the highly developed countries, in US, in Europe, they are still in shortage, and they are in many centers whom I know they are refusing to cover calls during the night, because these people who are doing good services, they reach a level of burning out since there is no enough people taking care of the stroke. So many programs are opened now, many training centers are opened, and the speed that the growth of the services needed is far way more than the existing task force and the workforce availability. So there are a huge room for improvement and development and training in this field. Second thing, there is a huge room also for the research and development. So the more we know, the more we do for the brain, the more we realize we know not much. So there are a lot of things need to be done regarding the imaging, regarding the tools. And there are a lot of techniques, a lot of procedures are coming in the pipeline. System integration, providing a stroke center, it requires a lot of integration. So you cannot work by yourself. There is no single man show or single specialty. So there is significant integration between different specialties, not only specialties, rather than involving the leaders and the management in the healthcare providers, in the Ministry of Health, in the private practice leaders, to have these services available and facilitate the access of the patient to the assigned stroke centers. So this cannot be done without huge financial support and sustainability of this financial support. And in return, there should be a huge revenue from these services to the healthcare providers. So there is a kind of way of win-win situation, because these patients, if they are managed appropriately in the right time, that will save the healthcare provider a huge amount of money. Though it can be very expensive at the beginning, but in the along the run, there will be significant saving, having the patients being managed correctly. Society information, there is a significant need in more societies, especially in our world in the Middle East, where we need legalization and legislation and credentialing for people who are performing such specialties, to have the appropriate credential and training to perform such a procedure. The technology also highly demanded in this field. So there is significant amount of technology regarding the devices that we use for the intervention, regarding the application app that you could evaluate the patient remotely before arrival. There is also technology in performing such a procedure using artificial intelligence, and even in different locations where lack of accessibility of physicians is quite difficult. So in nowadays, artificial intelligence could perform a significant role in covering the huge demand of the manpower. Public awareness campaign, this is a huge, there are still significant number of stroke patients not being treated. Actually, the real number that we are treating now, though we are sounds quite busy, they are not even exceeding 3% of the stroke patient who are in demand for such services. So if I give you exact number in King Fahd Medical City, which I'm primarily working in, we do for per year almost 150 cases. So this is considered 3%. If we manage to solve 100%, instead of 150 cases, we need to do 4,500 to 5,000 cases. So there are huge demand to provide for this patient. So the lucky ones that got the treatment are not even exceeding 3% of the candidates. Industry and active involvement, that is again a huge part which I touched earlier, but again, involving the IT, huge infrastructure requirement is necessarily, especially sharing all the platform with other hospital to avoid any repetition of exams and easy accessibility between patient information to avoid any repetition in exams, imaging, lab works, and this patient can be prepared for the intervention without any delay. So treatment of options for cerebrovascular disorders, there is medical therapy, which everybody knows, but now I'm concentrating on the interventional part, in addition to the availability of surgical intervention. That's surgical if you have for any complication that could happen, stroke, malignant ischemia, patient could go for craniotomy. If it's a hemorrhagic stroke, patient could go for needs EVD or some. So the integration between different specialties, especially neurosurgery, neurology, anesthesia, stroke team, that's what form the formation of or the need for the formation of stroke centers. So once you have this kind of a comprehensive stroke centers availability, this is where it comes to the definition of full integration for services pre, during, and post stroke care without any deficiencies in patient management. So you require multidisciplinary approach, which is a key for success of such services. The proper management is the multidisciplinary approach who can provide the best option for each individual case. So each case will be managed accordingly if you have the accessibility of all disciplines available. So the patient could choose what's the best way he can be managed. Let's go about numbers. Acute ischemic stroke. World Health Organization estimated 15 million stroke case per year, and 5 million are left permanently disabled. And there is significant poor quality of life for these patients, which goes which raised from 30 million daily and projected to 60 million LY in 20,000 worldwide. And expected out of 6 people will have stroke in their lifetime, and hopefully the awareness will cut these down. Acute ischemic stroke is a very common disease associated with high risk of morbidity and mortality. And speaking about Saudi Arabia, we have the we have 29 per 10,000 per year. Limited availability of medical centers is required urgently, and it is the leading cause of this, the second leading cause of death among the other disorders, and it is the leading cause of adult disability. Time is brain, as everybody knows. Urgent treatment of acute ischemic stroke is very crucial. And every minute pass in untreated large vessel brain losses, 1.9 million neurons die. So every minute. And 13.8 million synapses lost. And 12 kilometers, 7 miles, axonal fibers lost as well. And each hour passes without treatment equal 3.6 years of normal aging. So that's each hours equal 3.6 years of aging if patient not been treated. So this is the classical case of patient who has sustained the right MCA occlusion, and the CTA is the primary study. So the patient immediately will go for CT plane to assess any hemorrhage, whether in the primary hospital or in the ambulance. In certain centers, they have CT scan in the ambulance, especially in some centers in Germany and Calgary in Canada. And we patient taken for half an hours to the angio and intervention being done, and there is a complete right MCA occlusion. And you see now there is full recanalization. The good thing, this patient has a good collaterals and he has a full sustained, full recovery. So with respect to the availability of services, we'll talk about demographic assessment, which is the region that I'm working in, which is Riyadh region. So there is around 8 million population, and the 8 million population need a huge amount of services. 8 million, if I say that we need one neurointerventionist for each million, now with the SUST demand, you may reach the 5 requirement for each million. So 5 by 8, you need at least in Riyadh region 20 to 40 neurointerventionists for the coming years to be fully busy. This is indicate the map that you need really to distribute the map and provide the services based on the availability of comprehensive center in each region. The other thing, there are regions outside Riyadh which can be reached by remotely, either by helicopters services, which can be reached within 2 to 3 hours maximum time of flight. There is a projected number of growth in Saudi Arabia which has published, and which indicate the projected and the demand. So population growth in Saudi Arabia is 2.5 every year, and our population will increase significantly by the 2020 that we are in now, and to the age of 2023. So there is significant growth in numbers in Saudi Arabia. So this is a diagrammatic of organization management department that establish the appropriate comprehensive stroke centers, and which all center organization management department which require the committees, policy and procedures, by law, department units, organization chart, and management of notifications. In such an establishment, you need to have a clear vision. And specifically, I'm entitled to establish the neurovascular or neuroendovascular center of excellence in Saudi German, Riyadh. And we have a clear vision and mission and targeted structure that need to be focused on. So our vision is to be a benchmark in provision of specialized healthcare, providing the highest standard of neuroendovascular services. And our mission, we are dedicated to provide highly specialized, evidence-based, and safe healthcare enhanced by education, training, and research. This needs a significant pillar of excellence in patient experience, talent management, best utilization of resources, and research exchange. This required respect, honesty, loyalty, empathy, compassion, and teamwork. This is an example of patient who came with, he's 10 years old, and I have done this case 20 years ago, December 2000. It's not 2020, so 20 years ago, 2000, December 2000 in Christmas. And this child, he sustained a sudden headache while skiing. I did it in Montreal, Canada. And the father of this patient is a radiologist, by the way. So this patient had an angio, and the CT scan here shows subarachnoid hemorrhage. This is the bright things. The bright things in the sulci here is the diffuse subarachnoid hemorrhage. And there is dilatation of the temporal horn of the lateral ventricle. So there is mild hydro in this case. So this patient immediately taken to angio and has a special anomalies. He has an aneurysm here, but there is infraoptic accessory anterior cerebral artery. So this patient having abnormal vessel exiting from the optic nerve, medial to the optic nerve, and having aneurysm formation which has rupture. This is the right middle cerebral artery, and this is the left middle cerebral artery. Both anterior cerebral arteries are patent. This is the anterior communicating artery aneurysm, and this is the infraoptic accessory anterior cerebral artery, which is an anomaly here, and which is associated with the aneurysm. So this is the posterior communicating. Actually, this is not anomaly. This is normal, but this is abnormal. So we went ahead to coil this aneurysm. We published actually this case in the AGNR. And we did embolization that time, but during the procedure, we find out there is occlusion of the right middle cerebral artery. So the anomalous vessel, once you occlude, the aneurysm has spontaneously occluded. There is no harm to the anterior communicating artery system, and both anterior cerebral arteries are normal. So what has happened during the procedure, there is complication during the procedure, and the M1 distally the bifurcation has totally occluded now. So during that time, the only approved management is intra-arterial thrombolysis, actylase. And we did the intra-arterial thrombolysis after we secure the aneurysm, and the patient has complete recanalization on the right MCA. This is one of my first stroke cases, which was done successfully 20 years ago. So another case which I had in August, this is just an sporadic cases for illustration. This patient has significant decreased level of consciousness with confusion. The brain, actually, I came the weekend to my hospital and found this exams done, and the whole brain looks normal. However, there is questionable hyperdensity of the basilar artery. So we took patient for angiogram, and we did angio because we relied more on clinical in this case. And we find that the distal basilar totally occluded, and the mechanical thrombectomy was done during that time with recanalization. So CT scan next day shows this hyperperfusion of the contrast, which is okay, and there is all the stroke in the calcarine region. So patient made a good recovery. Then the significant amount of publication with respect to the intracranial mechanical thrombectomy came out, and started in the huge publication started on 2015, Mr. Clean, Escape, Refiscat, Swift, all of this, and all support the early management with intracranial mechanical thrombectomy for the large vessel occlusion. So the patient will have a CT scan, then followed by CTA immediately, without checking even the lab result for the renal profiles. And if there is a large vessel occlusion, this patient will go for mechanical thrombectomy with respect to the timing for thrombolytics. So the patient could have thrombolytic therapy in the first 4.5 hours, but even if the large vessel occlusion exists, patient should be go for mechanical thrombectomy unless there is only small vessel occlusion. The other important thing is the basilar posterior circulation. There is no clear, so this paper all concentrated on the anterior circulation. The basilar and posterior circulation is still, there is a huge debate with respect to the management. However, we rely more on the clinical situation, each by case clinical judgment, and I always recommend to do an MRI immediately to assess the posterior structure, posterior circulation, and posterior fossa structures prior to intervention. And the timing is there. I had a cases treated even 3 days after the attacks. Regarding the techniques that we are using in mechanical thrombectomies, aspiration thrombectomy is the first line of management. I think it's the best way to start with. And this is the paper published in 19 by Dr. Saddiqis and his groups. And interpretation, a direct aspiration as a first pass thrombectomy conferred non-inferior function outcome at 90 days compared with a stent retrieval first line thrombectomy. So the patient is better to do aspiration considering the cost, to cut down the cost. And if aspiration never exists, never works, we could proceed with other techniques like mechanical thrombectomy devices like stents or other. So we started with different devices, and this is systems available. There is a solitaire stent, there is a refast, and there is aspiration. There are a lot of models and stents available now in the markets, and most of them works appropriately, provided you choose the best one for each individual case. And in fact, I found some devices are soft, which works well for the earlier soft clots. Some clots are more organized or vegetated from the valves of the heart, which are very solid, and this can be needing, which needs more stiff devices, which all are available now. This is a MCA stroke on the right side with complete recanalization. They become common scenarios in most of the people. And this is the pre and post perfusion, which shows total normalization of the perfusion to the brain post procedure. Left MCA on the left side, total reperfusion post mechanical thrombectomy. And most of these patients, lucky enough, they are restoring their lives. This is a 88 years old lady. It came with the freeze level of consciousness and the confusional state, and become acutely locked in. And they had this is a basilar artery, which is totally occluded, just distal to the bifurcation, which is from the arrangement. You see the post, there is significant stenosis with irregularity, indicate the stiffness of the clots. So this patient has a complete recanalization with some clots dissolved, but this one with medical therapy, which I gave routinely around 5 to 10 milligram intraarterial thrombolytics, will take care of the distal emboli reaching out distally. So the medication most of the time work out well. So important to revise the recent American guidelines for acute ischemic stroke. This is the latest has been revised 2019, and the organization and integration of components, pre-hospital stroke management and system of care. Stroke system must be integrated, IVLT based, capable, and mechanical thrombectomy can be capable centers. So these centers must be able to provide such two ways of management. Thrombectomy requires patient to be at an experienced center. So the accreditation of each center to provide such services is, in my opinion, is very mandatory. So some people say we provide, because I have encountered many centers who said we are providing such services, and they find they are referring patient to us. And once I ask him, no one is covering. So there is no consistency in service providing such patients. So in such services, you need to have full coverage 24/7 to be able to be credentialed and to be ensured that you will be a reliable place where patient can go in. It's not really fair for patient to go to a hospital which is presumably providing stroke services and find out the service is not available, or it depends on wishful thinking that night is not working or weekend they are not available, or someone is not in vacation. So this is totally not acceptable. Pre-hospital stroke management and system of care. Increase utilization of acute stroke therapies and improve outcome via increase awareness of stroke sign and symptoms, maximize utilization of emergency medical services, optimizing pre-hospital management and triage, establish and continually improve quality of care stroke centers, ensure rapid transport across hospitals when necessary. So the patient needs to be managed as soon as possible. Within 10 minutes, you need evaluation by physicians. Less than 15 minutes, stroke, neurological expertise contacted. Less than 20 minutes, non-contrast CT scan or MRI needs to be done. Less than 24 minutes, needs to have appropriate interpretation of neuroimaging. Less than 60 minutes, initiation of IT RTBs, and the sooner the better to have the patient managed accordingly. So now in our center in KFMC, we reach up to 20%, 20 minutes from door to needle services. So the patient will come from entering the ER till they reach the angio suite, till the needle in 20 minutes. This is quite something which we are happy about, though we need to be, inshallah, constant all the time. So this is a recommendation, which is a long list. You may find all these recommendation within the guidelines. So we have restricted IPP workflow in our services in KFMC. I'll go through some examples. This patient, go from down up. This patient is a young patient who came with right MCS stroke. And we did all the images which appear to be normal. We did CT, CTA normal. The only thing clinically which in retrospect we find out there is discrepancy between the blood pressure on the right side being low and the left side being normal or the higher side. So we never stopped there. So some people or the insurance company, they said everything is normal. You don't need to have approval for the procedure. Okay, we still find out that this patient is really in need for something to clarify the reason why he is having a stroke. And we did angiogram, which shows a very tight stenosis. This is the aortic arch. And the innominate trunk is very, pinpoint, very tiny. Even I'm trying to pass the wire through the stenotic segment in the innominate trunk, and it's not going anywhere. So we, after a hard work, we managed to get it through, and we did angioplasty and stenting of the innominate trunk. And you see the right subclavian. Actually, this patient is not only under the risk of right MCA stroke only, though it can be a killer for him, but also he can go under risk of losing his right arm, as well as the right vertebral artery if it's quite dependent on it. So this is it carries very critical risk. And this patient did very well after we did this kind of procedure. So we did angioplasty and stenting of the innominate trunk, and we find out distally the patient having good peripheral and central circulations. Guidelines again is the key to ensure that these patients will go through the appropriate channel. This is the workout, the site of the journal that you find the guidelines available, so it is accessible and it's free for everybody. This is a 43 years old gentleman with recent recurrent right-sided weakness and visual disturbance. And again, you did the CTA, you find only possible some haziness and irregularity on the left PCA. The whole anterior circulation looks normal. This patient was on aggressive medical therapy because he was in recurrent attacks. However, there is still acute events happens to him. So this is MRI, it shows the acute. This is for me is the region, one of the branches of the posterolateral choroidal artery, left posterolateral choroidal artery, which is a branch of the MCA. And we did angiogram for him, and there is a P2P3 significant stenosis, and we elected to do angioplasty and stenting. The significant thing in this patient is there is small fenestration within the distal basilar artery. You see this fenestration, and this is carries significant risk if you do an interventional procedure. If you go rashly and you injure this point, you could rupture the vessel and the patient could lose his life. So we went to the distal P1, P2, and we did angioplasty. After angioplasty, you see here, you didn't see the PCA anymore. So it's very important to keep secure the wire inside the PCA. And what we did lately, we managed to stents. It's a wingspan stenting, both stents, and there is complete restoration of the flow along the B2, P3 posterior cerebral arteries, and we see the stents on the lateral, and this is seen on the frontal, which appears to be okay with the normalization of the flow. Patient with left MCA recurrent TIA, sometimes you have very severe stenosis. And this is the, again, patient with acutely on top of recurrent attacks. There is significant clinical suspicion, though the imaging doesn't just show minimal narrowing of the left MCA. We took the patient to angio, and we see there is just a questionable left MCA bifurcation stenosis. We did obliques and we found the left MCA before the bifurcation very tightly stenosed. We did drug-eluting angioplasty, and this is one of the newest balloons that we are using now. We did almost 15 cases, which is the first, I think, in the Middle East, in endovascular drug-eluting angioplasty, ballooning of the intracranial circulation with no complications, in fact. And this is post-plasty, which appears to be restored the stenotic segment. So this is the balloon within the MCA bifurcation, and you see the significant restoration of the diameter of the vessel. All these cases are done in the Saudi, German, and Riyadh. We had this guy who have left ICA, left MCA stroke, and they found difficulty to access the left common carotid. We went inside the left ventricle prior to the valve, and he had recovering the techniques, recover technique where we go and loop inside the artery in the left atrium and go within the vessels and having access, because there is no direct access from the aortic arch direct to the left common carotid due to difficulties on the origin. So we loop inside this is a technique which I think is very helpful. And this is distal access and over the guiding catheter, and we went to reach the distal left common carotid artery. We find out complete occlusion of the left internal carotid artery from its origin, and these are the externals. And we managed to have it opened, and we find very tight stenosis at the origin, possibly dissection. Has moved distally. We chased this kind of clots to the MCA, and we went distally, and we found also the clot reaching the superior temporal branches or part of the angular branches, and we went ahead to the MCA distally, and we clean up the clots with the stents, and there is complete restoration of the flow to the MCA. We went back to the stenotic segment, and we did angioplasty and stenting, and this is the final. The A1 and the right side are coming from the right side. This patient have a young PhD practitioner, and he complaining of sudden headaches with sudden weakness. And we did this angiogram, and this is the right vertebral artery, and shows this huge dural vascular malformation compressing the midbrain. This is the left vertebral artery, showing where the localized the lesion. We did embolization, and the patient has restored complete flow with no symptoms. So sometimes the vascular malformation could present itself as a suspicion of a stroke. 16 years old boy has sudden headaches and collapse, and it comes like a stroke symptoms with a severe headache without weaknesses. So this patient is suspected to have a brainstem lesion, and there is a huge dumbbell-shaped vascular formation compressing on the outlets of the third and lateral ventricles with dissection. So presumably there is a vascular aneurysm from the choroidal vessels which has dissected. And we took this. I published this case. This is what's never been published before. And this patient managed by doing an angio and find the posterolateral choroidal. Actually, the posteromedial. This is the posteromedial choroidal artery aneurysm with dissection, and we included, and the patient made a good recovery. If the patient dependent on the stroke side, this could lose the patient's life. This is a patient who have a huge MCA stroke on the left side. However, the patient is quite dependent on the left side. So there is always people talk about malignant MCA, malignant ACA. This is total brain malignancy, which cost the patient's life if no management treated. And in fact, this is a young patient who had COVID, and he is COVID positive, and we found complete occlusion of the distal ICA. However, as I said, it's totally dependent on the left internal carotid to supply the anterior circulation. And once we open the whole system, the whole brain circulation restored adequately, as you see. Another case of ACA stroke also, there is a team with weakness on the lower limbs, and the ACA is a paucity in filling, has a paucity in the filling on the left ACA, and the left MCA is normal. So we did A2 thrombectomy, and there is complete restoration of the flow along the left anterior cerebral artery. Some cases we face, there is a recurrent insufficiency with acute on top of chronic or subacute strokes. And this is what we saw in this patient who had very severe distal MCA, nearly subtotally occluded. And there is acute clots here, but this can be managed easily with either aspiration or stent retrieval. But about this significant stenosis, is something worthwhile doing it or not? We went ahead and we did angioplasty during the drug-eluting stent, and this is the recovery point immediately post-procedure, nearly complete restoration of the flow to the left MCA. So now what we are implementing now, and we are doing now, in addition to the acute ischemic stroke and large vessel occlusion, is doing angioplasty for chronically diseased patient, or even nearly occluded or subtotally occluded vessels, even M1, M2s, P1, P2, P3. We go to these vessels with a certain confidence, and especially if you have a real selection of patient with the appropriate tools. And I find one of the best tools I use now is drug-eluting balloon angioplasty, which works quite well for such patients. And thank you very much for listening. And I know the topic is very huge, and we could spend hours and hours, and we'll be happy to answer any question within my capabilities. And thank you for the organizers and the Saudi General Hospital in Riyadh for these opportunities to talk about the acute ischemic stroke management tonight. Thank you very much.
Now we will go for a question and answer.
Thank you, Dr. Sultan, for this very nice talk. These are really valuable informations about a very critical subject nowadays. And we hope in the upcoming days and upcoming years for the more development of centers of excellence for strokes to save lives and to prevent disability. I'm scrolling some of the questions we have. There is one asking about the treatment of patients have disability due to stroke. And I think this is quite out of our scope, because after stroke disability, it is about neurology and physiotherapy who can handle these cases. Our role is to diagnose the early stroke and how to prevent the damage caused by strokes. Second question, Prof. Sultan, it is about how can we diagnose TIA, transient ischemic attacks?
Thank you, Meg, and thank you for the one who is asking. Regarding the TIAs, I think this is a misnomer proverb nowadays. So it's a clinical terms, and nowadays I think we need to evaluate and examine these patients very carefully, because these patients who are suffering from TIAs more likely to sustain major strokes in the future. So this patient, it is good for them because this is alarming signs that this patient require something quite urgent to be evaluated. We need to do CT brain, CTA of the necks, or ultrasound of the carotids as well, or MRI brain on more urgent basis to evaluate the source of TIAs. And we could prevent these cases if there is significant stenosis either in the neck or intracranial vasculatures. The other thing, this patient could have ischemic heart disease, and this can be dealt well with the cardiologist. The other thing, this patient need to be worked up from the screening point of view by a neurologist with respect to the coagulopathy states, risk factors for thrombus formation, and all these factors needs to be managed accordingly. Okay, so I think the terminology of TI is and leave this patient alone is not correct anymore.
Of course. Thank you. And there is a question, what's the recommended actions for dealing with strokes in pre-hospital?
I think that the proper organization and module of care is very essential. So this patient, if he is presented to a remote hospital, this patient could have the imaging done, a CT scan, and if I receive the call while the patient is transferring, I could call my team and make everybody is available. I could review the images that's been done for the patient, and I set up my plan clearly before the patient arrives to my hospital. So there is a clear pathways for management and a clear utilization of services in other hospitals that can be done. The other thing that the patient can be given IVTBA if he's still within the window prior to arrival to our hospital to maximize the benefit of the intervention.
Another one, time to start anticoagulant in acute ischemic stroke.
The timing is not like cardiology, starts with nitroglycerin under the tongue, as I heard many from people know. In the brain, we have to exclude the hemorrhagic stroke, and this is very critical. You cannot give any patient anticoagulation or thrombolytics before the patient had scanned his or her brain to make sure there is no well-established strokes and there is no hemorrhage, and make sure the patient is still within the appropriate windows of IV thrombolytic therapy.
So the patient must do CT before, because
Exactly.
to avoid giving him
The medication
anticoagulant.
having the scan.
Oh, it's okay. Another question, I doubt it is about our topic or not, but anyhow, is asking, after treating stroke and the physiotherapy, what is the recovery percentage from this stroke and its consequences?
I think it's a huge question. This is a huge question, and it's there is a huge spectrum, because this scenario requires the patient age, which time the patient comes to the hospital, what are the services provided, and what is the magnitude of the stroke, and what is the cause of the stroke, and what is the underlying well-being of the patient. So there are so many factors involved in the outcome.
And another one asking about, do you recommend baby aspirin as a routine prophylactic from which age?
There is of providing any medication without having appropriate consultation with the physicians. So I think if the patient is eligible to have this medication, I think no harm, but randomly and as a prophylactic, I don't recommend it unless the patient is needed regardless the age, because still these medications have their own side effects.
And Dr. Hassan Zahrani, it is quite personal question for you, Prof. This is a really important specialty, and ask you if you have started a fellowship training in KFMC, and do you have a plan to have one in SGH Riyadh?
Actually, Dr. Hassan, for the question. And we already applied to have our KFMC fellowship program, and recently we got the approval for the KFMC program, fellowship interventional program, which is already in place now. So hopefully we'll start next year. And again, the private sector again is entitled to have such programs to meet the demands. And I have no doubts both centers and both groups will have the capability of establishing such services. And since there is significant willingness from the leadership positions and from the demands of the people, in addition to the needs of such a specialty for the public. Thank you, Hassan.
Okay, and I think this is a simple one, asking how can we differentiate between hemorrhage and thrombosis as a cause of stroke?
Again, we need to do the scan and the CTA. So most of the time we'll illustrate and clear up the plan for the patient management. So it's not a big deal for any radiologist who can differentiate between these two.
Okay. Any more questions? Okay, so that's the end of our great time we spent it with you, Prof. Dr. Sultan Al-Qahtani, and we are all thankful for your valuable informations and great topic we have with you this time. And we are hoping, inshallah, for more and more lectures from yourself, from your kindness. And thank you.
It's my pleasure.